All right, so I'm gonna come towards the first case. So what do you see on this ECG? So this is the time when I want you guys to kindly look at this ECG. And it's a 62-year-old gentleman with orthopnea, exertional shortness of breath, and pedal edema. So what do you see on this ECG? And I want you guys to kindly grab onto your chat ones and tell me the findings one by one. See, question number one, is it a sinus rhythm? Means do you see a P wave before each QRS? So anyone can answer on the chat box, and I'm gonna wait. So what are the P waves? P waves you can see, here's a P wave, there's a P wave before QRS, P wave before QRS, and the PR interval is not changing that much. But what you can see in the rhythm list down there, it is a little bit irregularity that you're seeing in the rhythm off and on. So far no one has put any comment in the chat box, but I want you guys to kindly break the ice and what do you see? How does the morphology of QRS in the V1 look like? Is it a wide complex or narrow complex? What do you guys say?
So chat is disabled. Can you enable it?
Chat is disabled.
Chat is disabled. Can we enable it? Can anyone write something so we know that the chat is enabled and you guys can input your...
No, it is disabled still.
All right, I'm here.
सर हैंड रेस करवा लें?
हाँ नहीं, हैंड रेस से नहीं होगा, लेकिन ये टाइप क्यों नहीं कर पा रहे? Because that's an important part of this workshop. हाँ,
मैं उसको 1 मिनट में अभी सॉल्व करता हूँ, जब तक आप हैंड रेस करवा लें, ठीक है?
हाँ नहीं, हैंड रेस नहीं. Basically, all right. So it's definitely a sinus rhythm, okay? And if you want to decipher this, you can see that there is a wide complex here. So you would say normal sinus rhythm, right bundle branch block, and look at the axis. Lead 1 is positive and AVF is negative. So it's a left axis deviation. So this is a bifascicular block. And this irregularity that you're seeing in lead 2 is an APC, which comes a little bit after some time. So normal rhythm, and then there is a premature complex. That's why you're seeing a P wave, which is buried here in the T wave. This is a little more pointy. And then there is a little pause for the reset of the sinus. And then you have another sinus, and then another APC, which comes in which the P wave prematurely is buried in the T wave. So the diagnosis in this ECG are 3, just normal sinus rhythm, APCs, and then there is a bifascicular block with a left axis deviation. So it's a left anterior fascicular block and right bundle branch block. Okay, so just simple diagnoses, looking at the ECG methodically. All right, coming to the next one. So very similar ECG, right? What do you say? So our observation is, question number one, P wave. Do you see the P waves? So there are these beats which has that alif madda or biphasic P. So there is an atrial enlargement. V1 has a RSR prime and it's a wide, so it's a right bundle branch block. There is a downsloping of an ST. So this is not normally an ischemic change. These downslopings in V1, V2 denote normally a bundle branch block kind of a finding. So whenever you're seeing P waves, even though there is not a real concordance with QRS, but still it's a sinus beat. The P is doing its job, the atria is kicking off, but there is a dissociation. You see the PR interval is progressively prolonging, and then there is a P wave prolonged QRS, P wave, prolonged, and then there is a gap. So that long gap leads to a very different morphology of a QRS, which is coming right after. And that is a small artifact, which is just seen over here. It's a pacing artifact. So this patient actually, although it's a 50-year-old asymptomatic male, so there is a pacing artifact, means he has a pacemaker placed. And most likely the AV nodal dysfunction was one of the reasons for this patient's pacemaker installation. This beat, which is very similar in morphology over here, is showing right before the third one. And you can see that these two are actually the paced beats. And in between the native complex of the patient is a right bundle branch morphology. All right. Do we have the chat function still enabled, or there's a problem still going on with it?
No, sir, I am working on it.
I should not take this long though. All right, so unfortunately I have to do my part and move on with the cases. So this patient had a sinus rhythm, a second degree type 1 Mobitz AV block, right bundle branch block, and a normal ventricular pacing functioning that we were seeing, because whenever there was a more pause from an intrinsic set rate of the pacemaker, then you would have a paced rhythm. An interesting reason that I want to just bring about this time, as you can understand that patient's own underlying rhythm is a right bundle branch morphology rhythm with a RSR prime, which was being seen at this ECG. This is what the native rhythm of the patient looks like. But when there is a paced rhythm, you know, the pacemaker lead is normally in right ventricle. So the right ventricular actually gets more earlier depolarization. And that's why, since the surface ECG is going to see as if there is a left ventricular lag in electrical conduction, that's why the morphology of a paced beat is like a LBB, left bundle branch block, because preferentially the right ventricle got electrically activated first. So just a learning point why the paced rhythm beat is actually showing a wide complex of a LBB morphology. All right. Very similar ECG that we just saw, 71-year-old female with palpitations. So I'm just showing this kind of similar ECGs in a go so that you can just consolidate your knowledge onto these. So what do you see on this ECG? So of course, it's a wide complex, sinus, and you can see the PR interval is again prolonging. So this is also a Mobitz type 2 kind of a complex. In which the rhythm is showing AV nodal block with a prolonged PR interval, and finally to a dropped P wave without a QRS. And then the system resets again. This also has left atrial enlargement. There's a right bundle branch block. And again, left axis, so it's a bifascicular block, just like we discussed earlier. So these are the findings that I want you guys to be able to pick. Sinus rhythm, left atrial enlargement, AV block second degree type 1, and a bifascicular block. And whenever there is a first degree AV block or changing variable block, you think of trifascicular block as well. All right, coming to the next ECG. This is a known cardiac patient who comes in because is not feeling well and is nauseous and is complaining of blurred vision. All right, so what do we see on this ECG? So right off the bat, tachycardia, bradycardia. So looks like it's bradycardia, right? Do you see P waves? Not really. So the QRS complex, T wave, and then there's a wave after that, and it's called a U wave, all right? And you can see the ST segments are sagging down. And this actually concave down kind of ST segments with a bradycardia and sinus arrest, no P wave. It's a junctional narrow complex escape rhythm going on. So this ECG is actually classic for digoxin toxicity. And if the patient is symptomatic with this, then of course we should think about reversing the dish toxicity by giving antibodies to dish. But overall, this is a classic sinus arrest or sinus pause with the AV junctional premature escape rhythm, prominent U waves, and normally with these scooped or sagging ST segments, you have to think about